Good afternoon, everybody. My name again is Ashely Darmiento. I'm a staff nurse here at Mount Sinai, and I work in the cardiac cath lab. I'm going to be talking today about cardiac rehab post-MI PCI and touch a little bit about TAVR and MitraClip as well. Some of you might remember me from last year. I was the one that cried on stage. But I won't do that again, I promise. And before we begin, I want to give a special thanks to Dr. Marianne McLaughlin, who couldn't be here today. She's the Director of Cardiovascular Health and Wellness at Mount Sinai Heart, and she plays a big role in cardiac rehab and growing the program and trying to get it to the patients in need. So what is cardiac rehab? Cardiac rehab, it's a program consisting of a multidisciplinary team, so keyword, team effort, and this team collaborates to promote and optimize the patient's well-being. So it's a very holistic approach, and it is by no means an individual effort, and most importantly, it's patient-centered care. It's tailored to the patient's needs. Not every patient's needs are the same, so it's a really great approach to patient care long-term. So we've all heard of primary prevention, and that's when we take the steps to avoid and prevent the disease process. But what we deal with mostly on a daily basis is patients that have already been diagnosed with the disease. So when we think about secondary prevention, we're thinking about slowing down the disease process, and the ways that we can do that is showing up to your follow-up visits, getting educated, taking your medications. As Jess mentioned before, diabetes plays a big role in coronary artery disease. So taking your diabetic medication, your dual antiplatelet therapy, which Dr. Sweeney touched upon, very important. But also, and what we sometimes forget, cardiac rehab is part of secondary prevention, and it plays a key role in improving patients' outcomes. So there are 3 phases to cardiac rehab, and they're a little modifiable. Phase 1, typically, nowadays we're doing same-day PCIs, so not necessarily an inpatient setting, but it's about getting to the patients, talking to the patients, letting them know what cardiac rehab is about, how it can help them. We're doing a physical assessment, figuring out what are their goals, what are their needs, and how we can get them there, creating the referrals, and ensuring enrollment. Education is a big part, and the nursing staff plays a big role in this because, the nurse practitioners touched briefly about cardiac rehab upon discharge, but there's a little bit more to it, than, oh, this will be good for you, and we'll go over that as well. Phase 2 is really the heart of the cardiac rehab process. It's in an outpatient setting, and this is where we continue to educate the patient regarding the disease process and talking about modifying risk factors, providing psychosocial support, and of course, monitored progressive exercise. But I want to make sure we understand that cardiac rehab is not just about the exercise process. They provide support groups, they provide education, one-to-ones. There's a lot of resources there, including doctors, nutritionists, physical therapists. So it's really a good way to promote overall health changes. And really, we have to make sure that we create positive behavior changes and assess the readiness for the patients to make that change. Phase 3 is outpatient as well. This is our transition period. This is where the patients are finishing up their cardiac rehab, and they're trying to incorporate it into everyday life. So it's important in this phase that they understand that this is not a temporary treatment. This is a lifestyle change that they need to incorporate in everyday life. I won't go into too much detail about the components. It's just something that you can see here and read through, but what I want to highlight is the readiness to change. Again, we can spend a lot of time telling our patients that they need to go to cardiac rehab, but if they don't understand the reasons why, and we'll talk about that, why cardiac rehab is important, and if they're not ready to make those changes, then they'll never make the necessary changes to improve their health status. Some more cardiac components. And then I just want to touch upon briefly here the scheduling. And again, it's patient specific. It depends on what their needs are, but on average, 24 to 36 sessions, an hour each, 8 to 18 weeks, and 2 to 3 sessions a week. It's very time consuming, and that's one of the challenges we have with enrollment. And we're working on ways to make that better and make it more convenient for the patient. So cardiac rehab is evidence-based. As nurses, techs, medical professionals, we love evidence-based medicine. It's because it's proven to work. So The American Heart Association and the ACC has made it a Class 1 recommendation. It's high priority. It's mostly because it decreases mortality rate by 50%. It improves your quality of life, reduces depression and anxiety. And I don't know if you've noticed, but there's some patients that are very apprehensive regarding physical exertion post-diagnosis of a MI. You know, you have young patients, 63 years old, you're still working, you have kids, you might have grandkids, you have friends, you go out, you work, you exercise, and then all of a sudden you are diagnosed with this MI and the LAD, you have a decreased CF, now you have ischemic cardiomyopathy, and you are being treated for heart failure. It's scary to get back out there and get your life back, but cardiac rehab can help you do that safely. This is just a graph showing the difference between patients who receive cardiac rehab versus, receive cardiac rehab is in blue, and people who did not receive cardiac rehab, and the mortality rate is significantly decreased in those patients that did receive cardiac rehab. So again, I can educate you and tell you that cardiac rehab is very effective for cardiovascular patients, but it's better to understand why that is. So it does reduce the severity of atherosclerosis. Aerobic exercise improves endothelial function, which increases and prolongs the release of nitric oxide, which, as we know, is a vasodilator, which then inhibits atherogenesis and thrombosis. There's also an anti-inflammatory response. And here at Mount Sinai Cath Lab, for all PCI patients, we monitor the CRP, which is an inflammatory marker. Now, we know that inflammatory process is directly related to coronary artery disease, so if reducing the inflammatory process, we are then in turn reducing the formation of coronary artery disease. There's also reduced RPP, which is the, sorry, I lost my train of thought here. Excuse me 1 minute. Sorry. Okay, so rate pressure product, which is how we calculate internal workload of the heart. And if we decrease the heart's oxygen demands, then we therefore decrease the ischemic threshold. There's also an improved balance between the sympathetic and parasympathetic nervous system, and we know that is related to decreased risk of sudden cardiac death related to ventricular arrhythmias. And for our heart failure patients with low EF, and some of them might be the TAVR and mitral clip patients, many of these patients with heart valve problems often experience cardiac abnormalities and decreased function capacity for many years prior to the treatment. So again, cardiac rehab improves overall cardiovascular health and function. And the last thing I want to touch upon is the increased production of endothelial TPA, the tissue plasminogen activator, which, to put it simple, degrades clots. These are some of our patients, Mount Sinai outcomes, and you can see here everything's moving in the right direction as far as, and then you have some lab values here, physical limitation, even depression. So when to refer? Not everybody qualifies for cardiac rehab. There are some patients that would not qualify, and we'll talk about them. But patients that really benefit from cardiac rehab are patients, the myocardial infarction patients, stable angina, stable being the key word, post-PCI, CABG, valve repair replacement, which again, TAVR clip, mitral clip, TAVR patients, and then heart failure patients as well. And then your contraindications, unstable angina, uncontrolled hypertension, uncontrolled diabetes, ST segments changes greater than 2 millimeters. Just because they're not indicated at this time doesn't mean that they couldn't eventually benefit from cardiac rehab. We just have to get some of these things under control before they move forward with cardiac rehab. So cardiac use rates, we're not doing so good in New York State, folks. It's 14% of people post-MI are being enrolled for cardiac rehab. and it's less likely to happen in the older population, female population, low socioeconomic status, and multiple comorbidities. So when you see these patients in the lab as an inpatient, please pay extra attention to these patients and give them a little bit of extra education regarding cardiac rehab and how it can help them. So why aren't these patients going to cardiac rehab? There's a huge referral gap. So of the patients that can benefit from cardiac rehab, only 35% of those patients are being are being referred for cardiac rehab, and even less are being enrolled. There's a lot of financial burden, and I want to point out for the cardiac rehab at Mount Sinai, that's the only one I could speak for, they really try to work with you financially, and also family commitments. It's a time constraint for schedules as well. And some of the ways we're going to combat that is home-based cardiac rehab. It's an alternative. I want to point out that patients need to be self-motivated for home-based cardiac rehab. You do have an initial consultation that is individually tailored for you, and frequent follow-ups. But a lot of the stuff you're expected to do on your own, and then we'll follow up. So you have to be self-motivated. And for home-based cardiac rehab, the mortality rate is actually even better for those who are receiving home-based cardiac rehab, meaning that it's less. So proposed solutions to barriers in addition to home cardiac rehab. There's physician factors, patient factors, and system factors. I won't go over all of them, but patient factors, we need to help motivate and provide transportation. We need to educate our patients and make it more affordable and more easier to get to. Again, with the home cardiac rehab, that would be very helpful. Physician factors, incorporating cardiac rehab into educational curriculum, and then system factors, and we need to work on that as well. So at Mount Sinai, the referral process has improved over the past couple years. It's now part of an EPIC order where the patients are automatically consulted for cardiac rehab, those who qualify, and then we contact them. The cardiac rehab contacts them and speaks to them, talks to them about cardiac rehab, and tries to get them scheduled in. This is just what it looks like for in EPIC here at Sinai. And this is just a little thing that you can use as a tool set to educate your patients. Sometimes it's good to really put things into perspective. When you talk about hip or knee or shoulder surgery, these patients that are scheduled for these surgeries already know that they're going to rehab post-surgery. They have their plan already in set. I don't understand why we don't feel it's as important for cardiac rehab to be a part of that process as well. You can live without a hip, you can live without a knee, but you can't live without your heart, so we need to take extra care of it and spend a little bit more time making it better. So it's something to put into perspective for the patients to allow them to understand. Because a lot of times the perceived benefit is low for the patients to go to cardiac rehab. So this is one way to help them understand. And in conclusion, if you learned anything today about this cardiac rehab, these are the take-homes. I want you to know that cardiac rehab reduces mortality rates by nearly 50%. That's a big deal, especially if one of these patients are your family members or you're yourself. There's huge educational and referral gaps. We need to work hard. That's part of our process. Nursing is to educate our patients and ensure that patients understand why they're being referred and what it can do to help them. And just be a part of the process. Be a more active participant in referring for cardiac rehab. It's not just the providers, it's the nurses that need to educate as well. And this is our acknowledgements. Thank you.